In the mid-20th century, heart disease carried a grim certainty. The medical consensus held that blocked arteries were an inevitable consequence of growing older. Physicians relied heavily on a mechanical metaphor. They viewed human blood vessels like plumbing. Once an artery began to clog with calcified deposits, it was thought to be a one-way street of decay, narrowing until a fatal blockage. This dogma persisted because researchers could not track the slow progression of arterial disease in living patients. Their understanding was based entirely on post-mortem autopsies. To find out if this biological decay could actually be stopped or reversed, science required a perfect biological mirror, an animal model that precisely replicated human vascular architecture. Standard laboratory animals like rodents and rabbits fell short. Their bodies do not process or transport circulating cholesterol in the same way humans do, making them poor proxies for coronary disease. A shift in research occurred when scientists turned to non-human primates. Their coronary structures and lipoprotein biology, specifically the behavior of ApoB particles, closely match human systems. Starting in the 1950s, the rhesus macaque became the primary historical subject used to test how diet-induced disease develops in a primate heart. Other species, like baboons, provided a different baseline. Their natural genetic variations and aging patterns offered a long-term model of plaque buildup over a lifetime. With these models established, researchers could finally ask the defining question: if we force these primates to develop severe heart disease, is it biologically possible to put the condition into reverse? To induce atherosclerosis, investigators fed the primates experimental diets loaded with cholesterol and saturated fats, mimicking the nutritional drivers of human disease. The resulting arterial damage was driven by a massive surge of ApoB-containing lipoproteins circulating in the bloodstream. Under a cumulative exposure model, excess ApoB particles pass through the endothelial lining and accumulate inside the arterial wall over time. The immune system responds by creating foam cells. Eventually, this mass swells into a lipid-rich plaque that physically narrows the channel for blood. Years of this cumulative exposure forge a volatile, ticking time bomb inside the artery wall, mirroring the mature lesions found in human adults. In 1970, a team at the University of Iowa, led by Dr. M.L. Armstrong, produced the first definitive anatomical evidence of coronary regression. They took macaques with severe coronary stenosis and switched them from high cholesterol feeds to either ultra-low fat or polyunsaturated corn oil diets. The physiological response was immediate. The levels of circulating atherogenic lipoproteins plummeted back to healthy baselines. Normalizing the lipid profile revealed that early-stage plaques possessed high metabolic plasticity. The lipid pools rapidly dissolved and cleared out of the artery wall. This rapid clearance was most obvious in young, early-stage fatty streaks in models like the squirrel monkey. But human heart disease usually involves decades-old, mature lesions. To see if these complex blockages could also be erased, long-term programs at LSU and Bowman Gray tested the reversibility of severe, multi-year plaques. They found that while extreme lipid lowering successfully drained the soft, volatile cholesterol and stopped inflammation, the physical size of the plaque did not always shrink proportionately. While the liquid pools were cleared, dense collagen scars and hardened calcium plates remained stubbornly embedded inside the artery wall. This persistence of calcium initially looked like a failure to clear the blockage, forcing researchers to reconsider what cardiovascular healing actually requires. If the dense calcium scar does not disappear, the question is why aggressive cholesterol lowering still drastically reduces the risk of death. Trials at Bowman Gray provided an answer. The artery itself undergoes a physical transformation to compensate for the remaining scar. This is outward remodeling. The artery's outer wall stretches outward in all directions to accommodate the plaque mass. This expansion effectively doubles the opening for blood flow, restoring healthy circulation even though the plaque remains. Beyond the expansion, the vessels regained their ability to dilate. A diseased vessel can return to being a healthy conduit without erasing the physical evidence of the disease. These primate discoveries show surviving heart disease doesn't require surgically scrubbing arteries clean of all plaque. The primary objective is to aggressively reduce the concentration of circulating ApoB particles. This drains the highly active, volatile lipids from the core of the plaque, neutralizing the immediate threat of rupture and a sudden heart attack. This reality contradicts the old myth of the rusting pipe. Increasing calcium density is often a sign of a stabilized, healing plaque. This 40-year research record shows atherosclerosis is not an inevitable one-way decay of aging, but a dynamic, manageable chemical equation that we have the power to control.